Hello. Good afternoon, everybody. My name is Helen Aviard, and I'm the programme lead for the Professional Doctorate in Nursing and Midwifery here at the Oxford School of Nursing and Midwifery. I'm very pleased to welcome you to our second of our Nursing Reimagined webinars. Here at the school, we run a very active doctoral programme, both PhD and doctoral students. Today, we are very pleased to introduce the work of one of our educational professional doctorates and one of our PhD students, that's Dr. Charlotte Maddison and Dr. Julie Cook. We want to showcase these projects in order to illustrate the practical and impactful work that our students are doing. And although these projects represent the work of doctoral students, their work is practical and applicable to students and colleagues of all levels working within the profession. We also want to demonstrate the alignment between these projects and to show common themes that our researchers have identified and how different projects might relate to each other, as is the case with Charlotte and Julie's projects. Our doctoral students consistently identify challenging areas in their studies and areas in which development is needed and where we need to challenge the status quo. Today, we look at the potential role of nursing homes in our nurse education system. Julie will explore how these are sometimes perceived by everybody who works within this area, and Charlotte will identify some potential ways forward. We are recording this webinar and we will be taking questions at the end. Please do put questions in the Q&A box. I would now like to hand you over to Dr. Julie Cook, Dr. Charlotte Maddison, and to Dr. Claire Merriman, who will be leading the discussion today. And our overview of the session is just on the screen there now. Julie, over to you.
Thank you, Helen. Yes, very warm welcome. My name is Dr. Julie Cook, and I completed my PhD with Oxford Brookes University back in December 2024. My PhD used interpretive phenomenological analysis to explore 8 nurse educators' experiences and perceptions, really, of supporting and developing student nurses for placements in nursing homes. And among many things that came up was the idea that these nurse educators felt that fundamental care was being relegated in their curriculum in favour of things that the NMC future standards were bringing out, such as cannulation task-related skills, which is where they feel that the fundamental care was being relegated. But first of all, I'd like to provide you with a little bit of an overview of why it's important, and then I'll explain a little bit more about some of the background of that fundamental care issue. So the workforce of registered nurses plays a real pivotal role in delivering essential healthcare and shaping global policies. And alarmingly, as the population and the global population increases, the World Health Organization predicts that a growing shortage of 4.5 million nurses there will be by 2030, with the worst affected areas being Asia, Africa, the Eastern Mediterranean and Latin America. Additionally, as life expectancy rises alongside improvements in healthcare, many in this growing population will be people over the age of 65. And the United Nations projects this number will triple by 2050, with the population over 65 way outnumbering those who are under 18 by 2080. So the older population naturally brings with it increasingly complex health and social care needs, which creates a significant challenge for nursing, including community nursing and, of course, the social care sector, particularly in developing regions. And this poses a serious challenge to the ability of global healthcare systems to meet the complex needs of an aging population, requiring not only those technical skills I was talking to you about earlier, but also the significant fundamental care that will need to be delivered alongside those. Now, fundamental care has been defined as a set of caring actions that focus on a person's essential needs, ensuring that both their physical and psychological well-being and encompasses a wide range of elements, including attention to physical needs such as nutrition and hydration, psychosocial needs, communication and dignity, and relational aspects of care as well, including empathy and active listening. And despite fundamental care being valued as a core or essence of nursing care, the research really indicates that nurses who specialise in technical skills tend to be held in much higher regard within the nursing community than those who focus on fundamental nursing care. For example, such as those nurses that work in nursing homes. Now, this perception is especially prevalent in clinical settings such as nursing homes, where the majority of nursing care sits within that fundamental domain, albeit within complex considerations of comorbidities, polypharmacy, coordination of multidisciplinary support. And therefore, while theoretically acknowledged as the core of nursing care, the tacit skills are often afforded a much lower priority than technical task-based skills. Creating a perceived deficit in the knowledge and skills of registered nurses working in nursing homes. That creates the belief, of course, that to be a good nurse, one must have extensive technical skills from acute hospital settings, which devalues fundamental care and jeopardizes the capacity of healthcare systems worldwide to provide adequate care for older adults. So this professional devaluation of core nursing knowledge and skill endangers the nursing workforce and contributes to the growing stigmatization around nursing older people within that workforce, with working in the field holding a much lower status within the profession of nursing. And Skills for Care data stated that to help social care sector understand workforce challenges, that such stigmatization gives rise to a higher turnover of staff, which is expensive for providers and results in a less skilled workforce with less experience and ultimately leading to poorer health outcomes for older adults in care settings such as nursing homes, which severely suggests that by increasing the status and increasing the thoughts and value that we place on those nurses, it will automatically increase the level of care and the confidence that they have in the job that they do, that's making a real difference to the community. So although those RNs in nursing homes are specialists in an often complex care of older people, the RCN suggests that they do feel undervalued. They do feel as if the job they do isn't as good as the job that their acute setting colleagues do in the acute hospitals. And this is compounded by a persistent issue in nursing education in the United Kingdom. For example, research indicates that while students are really positive about working with older people and working with older people in nursing homes, they worry that those placement experiences might not meet the registration requirements set by the Nursing and Midwifery Council in their standards, due to the concern that the more tangible technical skills, such as venipuncture and catheterization, they seem to dominate the nursing curriculum. And similarly, the division of those skills also determines the way educators develop curricula, with a focus on attaining procedural skills in a tick box approach that the NMC seemingly demands. And in turn, this influences the values of student nurses who often believe that becoming an RN requires the achievement of those technical task-based skills, which of course it does, but it doesn't only require that. The results merely tokenistic inclusion of fundamental nursing care in the curriculum according to those 8 nurse educators that I spoke to. That's compounded by the current nurse education policy and as shown in my PhD study as well, that confirmed that these nurse educators really do feel that the future nurse standards are heavily emphasised practical technical skills and therefore devaluing, in their opinion, fundamental care in their programmes. And now this movement away from placing fundamental care as core knowledge across the curriculum leads to devaluing of placements in older people care settings as students progress through the course, so ultimately resulting in avoidance of this career path as they become third years and newly qualified nurses. And also findings from my doctoral study suggest that academic nurse educators who recognise the value of nursing home placements, so colleagues that recognise and see the value of those nursing home placements, they perceive a lack of enthusiasm and knowledge from within their faculty colleagues to effectively represent nursing older people as a valid specialist placement and career choice, which compounds this belief even further. So student nurses' experiences can therefore reinforce this idea that nursing home placements only offer fundamental care opportunities such as assisting with personal needs, nutrition, elimination, etc. And my study concurs with this perspective, suggesting that fundamental nursing care is valued by students at a basic junior level, and this is when many students attend clinical placement in nursing homes. However, this sense of value is lost as they progress through nurse education. With students perceiving that fundamentals of nursing as tasks for only junior staff. So for example, if they can do this straight from home, why do I need to attend nurse education? A return to older people care environments later in the course, where managerial and coordinational aspects can be learned, encompassing comorbidities, polypharmacy and complex care planning, might expand those novice nurses' understanding of the expertise required within the field of nursing older people by those nurses. This approach would place fundamental care considerations consistently at the core of learning throughout the curriculum, that spiral learning throughout the curriculum where fundamental care keeps being fed in and recognisably being fed in, while integrating more complex and advanced practice skills and nurse education to re-establish a balance focusing on fundamental care alongside those technical tasks throughout all of the levels. And continuing that education in person-centred fundamental care throughout nursing programmes wouldn't only benefit students, but also begin to address urgent global healthcare challenges. And my PhD study within the confounds of fundamental care recommended the reform of nurse education should be supported by targeted research to provide the necessary evidence base. And this future research could include curriculum audits, so a detailed examination of what, when, and how fundamental care is currently taught through the curricula globally, where it's recognised to be taught. Perceptual studies, including investigations into the attitudes of students, educators, and clinicians towards fundamental care and its role in different healthcare settings. And observational research, so direct observation to see exactly where that where that teaching and learning actually takes place. And these findings must be used to secure buy-in and investment from faculty leadership in nurse education, research funders and policymakers. And their support is crucial for implementing new educational strategies that promote a deeper appreciation for fundamental person-centred care across all healthcare settings, including nursing homes. And these changes would not only improve patient outcomes, but also help the nursing profession by challenging that stigma which is associated by providing fundamental care to older people in nursing homes and indeed all care settings. We know it happens, but it's not often very evident in documentation, for example. And that would highlight the rewarding and expert nature of fundamental care, of something that all good nurses do. We can attract and then retain a skilled workforce, ultimately making careers in older persons care more appealing and ensuring that higher standard of care across all settings for our ageing population. And a shift in policy is essential to combat the devaluation of fundamental care, ensuring our ageing population receives the high quality nursing care that they deserve. And that is the end of that section of the presentation.
Okay, thank you. So, Sophie, are you able to move the slides on for my presentation? Thank you. Okay, so many thanks, Julie, for sharing those insights and recommendations from your doctoral study. What I'd like to do with this part of the presentation is to build on your findings and discuss how we can address the challenges that you've outlined through the Fundamentals of Care framework. So the framework was developed and is continually refined by the International Learning Collaborative, or the ILC, spearheaded by Professor Alison Kitson, now based in Adelaide, Australia, but was originally founded in 2008 at Green Templeton College, Oxford University. So we have very close connections with them. For those of you who are not yet familiar with the ILC's work, I highly encourage you to explore their resources. For me, they are transformative for nursing practice, and we will share the relevant links with you following this webinar. So for me, it's about reclaiming the nursing identity. So in 2013, Kitson and colleagues published a landmark position statement. It was called Reclaiming and Redefining the Fundamentals of Care. This wasn't just a paper, it was a manifesto with 4 clear aims. First, to repoliticize care. So moving the basics from the bottom of the clinical hierarchy to the very top of the professional agenda. 2, it was to establish a conceptual framework by creating a shared language for practice, education, and for research. 3, it was to challenge the task-orientated culture in many care settings, and particularly in some of the areas which Julie has just described, moving us away from a tick box mentality. So, for example, a bed bath or a meal is not just a chore, it's a critical opportunity for clinical assessment and therapeutic intervention. And 4, to drive evidence-based research, ensuring that these core actions are underpinned by science and evidence-based practice. Essentially, Kitson argued for an integrated, person-centred approach that restores the soul of nursing. So I think before we move further forward, we need to think about what we mean by basic. So we ask the question, what do we actually mean by basic care? Kitson and colleagues identified 12 core needs, which Julie's already mentioned, but they are nutrition, mobility, sleep, communication, hygiene, elimination, safety, comfort, emotional support, dignity, privacy, and choice. I think all of those would be familiar to all nurses and non-registered practitioners on this call. But in many settings, these may well be referred to as the basics. That word is a double-edged sword. Basic often implies simple or low-skilled, which is perhaps why these tasks are so often delegated to non-registered staff, and perhaps why students often view a placement with high levels of basic care as less useful as a learning environment. However, Faux et al. In 2017, as part of the ILC, the International Learning Collaborative, refined this by showing that these needs are interdependent. They categorize them into 3 layers: the physical, the psychosocial, and relational. You can see the framework that they've created in the diagram on this slide, and you can see some of the components of the psychosocial, physical, and relational aspects of the framework. They make reference to rest and sleep, personal cleansing and dressing, comfort, safety, mobility under physical. They talk about communication, respect, education and information, dignity, emotional well-being, and privacy under psychosocial care recipient needs. And under relational, they talk about being empathetic, helping care recipients to cope, engaging with recipients, supporting and involving families and carers, being present and being compassionate. And they also refer to active listening. So whilst communication is already identified, being active when we listen to our people in receipt of care is an important part of our relationship building. Essentially, they argued that you cannot meet a physical need effectively without a relational connection. To help a patient with elimination or hygiene while ignoring their dignity is not nursing. It's merely completing a task. So why does this distinction matter? Because the framework conveys a powerful message that care is not basic, it is fundamental. If we consider nutrition and hydration, these are not just comfort measures, they are clinical interventions. We know that a failure in basic hydration leads to delirium, delirium leads to falls, falls leads to hip fractures, and hip fractures in older patients particularly frequently lead to mortality. So there is a direct, measurable line from a basic failure to a fatal outcome. The Francis report in 2013 in the UK was a watershed moment because it proved this at scale. It showed that when a healthcare culture prioritises administrative targets over fundamental care, patients die. The basics are, in fact, our most important safety net. So, our challenge with the curriculum and our vision at Oxford Brookes University. Despite this, we face a recurring challenge. Nursing students often struggle to value these fundamentals, or so we're told. Research shows that when students don't see the basics as high-level nursing, they push back against placement in areas like nursing homes, viewing them as low-value learning environments, which Julie has identified within her research. However, this is a significant missed opportunity for professional development. And at Oxford Brookes, we believe pre-registration education is the critical intervention point. We must ensure these fundamentals are deeply integrated into a nurse's professional DNA from day one. Could I have the next slide, please, Sophie? Okay, so our proposal is twofold. First of all, a scaffolded curriculum. We are already in the process of implementing a model that uses the fundamentals of care framework to weave the nurse-patient relationship, physical and psychosocial needs, and the context of care throughout all years of study. For example, in year 1, which we would class as a foundational stage, students are introduced to the fundamental skills such as nutrition and hydration and the other skills or basic needs identified by Kitson and colleagues. This is framed through the lens of the fundamentals of care framework. In order to make links between theory and practice, students participate in reflection on their first placement. We ask them to make connections to the fundamentals of care framework. We are awaiting final ethics approval to formally evaluate this and will disseminate our findings at the conference, the ILC conference in June. In year 2, we move to the relational stage, where students will build upon their foundational knowledge and experience by making connections to building therapeutic relationships. Instead of moving away from the former activities, they will use the time spent on physical care activities to assess cognitive changes, provide emotional support, and in building trusting relationships with patients and families. The nursing home environment will provide a prime opportunity to do this. In year 3, the systemic stage, students will start to engage in leadership and prioritisation. Students can start to use the framework to identify silent risks, such as a patient who has not had adequate oral intake, or a patient who is becoming socially withdrawn. Only by continuing to use the skills learned in years 1 and 2 can they do this. Connections with patients at the bedside becoming an increasingly important part of the assessment of the patient's clinical status. Could I have slide 3, please, Sophie? The second proposal or approach is that we strengthen practice partnerships. We have very good relationships with our practice partners at the Oxford University Hospitals and Oxford Health. And we are working collaboratively on the National Fundamentals of Care Network. What we'd like to do is to further engage our nursing home partners to ensure that they can make links between theory and practice, and that they are visible to our students. We want our students to see that a nursing home isn't a place where nothing happens. It is the gold standard for mastering the most complex fundamental care a person can receive. We aim to collaborate with our partners to evaluate the impact of the Fundamentals of Care framework within the curriculum. And we would also welcome wider opportunities to collaborate within the UK and also globally. Thank you for listening, and I look forward to your questions.
Thank you, Julie and Charlotte. For those of you that don't know me, I'm Claire Merriman. I have a joint role across both the Oxford University Hospital Foundation Trust and Oxford Brookes as a clinical academic and somebody who supports research capacity and capability across the nursing, midwifery and AHP workforce. And those of you who do know me know that the Fundamentals of Care and the International Learning Collaborative are very, very close to my heart, and also I have been part of that organisation for many years, so I am really, really pleased that we're able to work on this together and hopefully make some changes. I'm just going to look to see if there's any questions in the chat before I actually start the questions. There isn't any questions so far, but please put them in. So I'm gonna start, if that's okay, I will take the privilege to start with a question for you, Julie. Julie, really great work that you've done. I just wondered if you could think about or tell us how you think we can start to change this narrative that nursing homes are, in a way, I think you've described it as a poor relation in relation to, you know, where we have our placement. So how do we start to change that narrative so that nursing students and maybe other educationalists and clinical practice can actually recognise how important those placements can be as a student nurse to develop fundamentals, person-centred care?
I think that's a really good question. Thank you, Claire. I think one of the things that we can do as nurse educators is really begin to work more in collaboration with our nursing home colleagues as well as our NHS colleagues. I think part of my research also demonstrated that the communication links between nursing homes and the university were a little bit more disjointed, perhaps, than they were between the NHS. And that made it difficult for nursing home colleagues to join in. It made it difficult for them to have their point of view. They felt like a lone voice. They feel unsupported. And it really is down to the link lecturer or the academic advisor, as other universities call them, to really begin to try to create that link and make them feel more interested, more involved, include them in teaching. You know, where we deliver some teaching sessions, we call upon nursing specialists from the NHS, but actually let's call upon nursing specialists from our nursing homes as well. Let's get them involved in teaching the students. Let's get them involved and understanding what nurse education requires, so that then they can also see how they might contribute, and what they do is a contribution. Because what they see, from my experience at Oxford Brookes, is they see a list of things that can't be achieved where they are, instead of the list of things that can be achieved in the nursing home where they work. And so I think it's about bringing the nursing homes, so to summarise, bring the nursing homes closer, work in closer collaboration, get them teaching as well so that they understand what the requirements are, and so that they understand that we are collaborators and we're not working against each other. And I think once that happens, that will begin to feed through the nurse educators and the students alike, and people will begin to see them in the way, in that lovely aspiring way that they see the cardiac specialists and the respiratory specialists, and they then begin to form career pathways in their minds about what they want to do going forwards.
Lovely, thanks very much, Julie. Charlotte, we've got a question from Carrie, if you wouldn't mind answering this. It says, I wonder if you have considered the fundamentals of care in small community hospitals, as students often reflect on the different approach to care they have experienced in placements in those. So I suppose what Carrie's asking, can you expand your project into the community hospitals as well, Charlotte?
I'd love to. No, I think you're absolutely right. I think the important thing to say about the proposal to the curriculum application of the fundamentals of care framework is that this is across the whole of the curriculum. So we would want our students, irrespective of their placement, to be sort of operating within the fundamentals of care framework and reflecting on the care that they experience through the lens of the fundamentals of care framework. I think that the current projects, if you like, that obviously Julie's really passionate about and I am as well, is to help engage with nursing homes. But I think that there are probably lots of different areas of practice who would, welcome that engagement too. So certainly we could expand that to the community hospitals, but small steps, and we will, hopefully we can do that.
Thank you. And then Sue Schutz has asked, well, both of you. So if we start with Julie, how does the engagement of student nurses and RNs intersect with the part of the HCA and AAs and nursing associates play in the care context? So if we start with you, Julie, and then Charlotte's got anything else to add to this very interesting question there from Sue. Not surprised.
Lovely. No.
Challenges like this.
Hi, Sue. Lovely for you to ask that question. And yeah, I think that as you know, the nursing support worker role and the registered nursing role really do cross over quite considerably in terms of fundamental care. I think the difference between the two roles is the accountability, as you're aware, but also that the registered nurse the student nurse that comes into the care, into nursing education with the idea that they've done it, is possibly because nurse education is seeing it as a task and not, like Charlotte has explained, we need to see it as that fundamental part of the care that leads forward and creates that golden thread of care all the way through to the end. And so, for example, in my research, nurse educators had the impression, the perspective from their student nurses on their programs of why did they even need to be on a nursing course if that was all they were required to do, and therefore that work must be basic. It's uneducated. You don't have to have had any training whatsoever to be able to do it. But actually, I think if we then approach it as nurse education, as this is your accountability, your responsibility, in order to assess your patient properly, this is what you must be looking at. This is what you must be seeing. If you are washing your patient, for example, you are able to observe their skin. You're able to do that, and then you're able to make evidence-based decisions based on what you've seen. Whereas, of course, your healthcare assistant and your support worker might not. They might be trained in such a way to see what's normal and not normal, but they wouldn't be making those decisions. And I think it's really important that we continue in nurse education to really reinforce how fundamental care can help your clinical decision making, and how that might be different from the healthcare support worker and the advanced I can't think of any other roles off the top of my head, and they're all listed
That's an associate, maybe.
Sorry, having
That's
abbreviation nightmare here. And I hope that answers your question.
Yeah.
But I really do think that accountability and responsibility aspect is key there.
Charlotte, do you have anything to add to that?
Yeah, I mean, I think what Julie said is absolutely right. I think one of the problems is, and I think there are lots of sort of extrinsic factors that's driving this, that in all areas of practice there is very much a focus on the tasks that need to be done, and I think there have been some comments there in the chat. And that that could be workforce issues, shortages of staff, etc., or it could well be that that's just how how things have just evolved and have happened. And Julie talked a lot about the NMC and its task focused, particularly with the technical proficiencies. And I think that there's certainly truth in that. What I would do is go back to the NMC proficiencies, the standards, and think about what is it that we are expected to provide to the person in need of care. And essentially that's person-centred care. So what does that mean? And how do we ensure that the person in need of care receives person-centred care? If we take it from that perspective, rather than focus on the task, we're thinking about who's the most appropriate person at this moment to deliver that particular aspect of care. The other thing is that the NMC are very clear about registered nurses are responsible and accountable for the assessment of patients. Nursing associates monitor the care that's been developed, and we would expect our non-registered support workers, who will have had some form of training as follows the Francis report, to have the competence to be able to deliver the care that's been prescribed and implemented, if that makes sense. So I think that we need to ensure that that framework is in place, and the fundamentals of care framework can help with that. But I think going back to Kitson and colleagues' comment that they wanted to sort of bring sort of basic care, if we use that word again, to the top of the professional agenda and take it away from the bottom of the hierarchy, that's what we need to be thinking of, constantly thinking about this fundamental, this basic care, if people are going to describe it in that way, is actually essential care, and we need essential knowledge and skills to be able to deliver that. So I think
that's thanks really Charlotte, because that actually was one of my questions for you. I'd actually written down that you put that the fundamentals of care needs to be at the top of the professional agenda. So how, as a nursing workforce, many of us on this call will be nurses in different roles. Mine is much more in the research agenda now, and I'm very much on the forefront of clinical practice. I walk around acute care wards nearly every day, see the fundamentals being delivered in very different standards and different ways. And when we talk about the fundamentals, come across some of the negatives that you talk about. But on the other hand, we have the harms. So we see the pressure injuries on a daily basis, the increased footfalls, that are happening because of fundamentals, people being undernourished. Because they're not having their nutritional needs met. I could go on, around, I had a story the other day how somebody got custard on their roast dinner, because the people didn't know what the custard was for, and so forth. So how do we start to get, influence, policy, government, the national, NMC and so forth, to ensure that we get the fundamentals at the top of the professional agenda? What can we do? I suppose I'm asking, what can we do?
And that's a great big question to ask, isn't it? But I think there are lots of different potential answers, and so what that means is it's quite a complex answer. But I sometimes wonder about philosophies of nursing. We used to talk about philosophies a lot in the olden days, and sort of each environment would have their own particular philosophy, which then would inform the care that was delivered. And if the team, subscribe to that philosophy, then you would hope that they will then subscribe to the care delivery system which has been agreed. And I do wonder about care delivery models. What are the care delivery models? How is care organised? How is it planned? How do each member of the team understand and identify the contribution that they're making? And I just wonder if there's some opportunity for some work to be done in terms of observational research. The other, obviously, we've had some research completed recently by one of our colleagues, Dr. Carol Ford Johnson at OUH, who looked at observed interactions between registered nurses and patients during sort of medication rounds and using electronic records. And that was very interesting, the findings that have come from that. So what are the barriers that are preventing nurses from engaging in a more authentic way with patients? And what can we do about it? If we're not happy with what we're seeing, how are we going to change that? And I think engaging staff at sort of ward level, clinical level is likely to be the only way forward. What do they think we need to do to change this? So I think there's lots that we could talk about, but looking at workforce configuration, care delivery models, learning from the research of some of our colleagues, and engaging practice to help bring about changes.
Lovely, thanks, Julie. I wonder if Lucy Speakman has just put a comment in the chat, but I wonder whether you could answer the last bit. Was how do you convince all nurses to believe that this is the core of what we do, when many of them prioritise and value being aspiring doctors? So I suppose a bit like what you were saying, they want they like the task. They see I remember when it first came in, the venipuncture, they will have to do venipuncture and cannulation and listen to hearts and that physical assessment, which obviously is important. But so what's your view on that, Julie?
Yeah, and it's a great question, Lucy. I hope you're well. I think what we have to do first of all is remember that although there's a lot of poor fundamental care going out there, there's also a lot of really, really good fundamental care going on out in clinical practice at the moment as well. I think what we need to acknowledge is that even when that really good fundamental care is going on, it's not always recognised as being contributory. So I think what we need to do is really bring it right back to the very, very beginning. This is what nursing is about. This is what you need to be able to do and demonstrate and understand why you're doing it in order to be a good nurse. And it starts with this. And when you're doing venipuncture and cannulation, for example, because they are the key things that keep coming up, aren't they? Time and time again in nurse education. When you are delivering and you're doing your venipuncture and your cannulation, actually they are just adjuncts to delivering superb person-centered care. And to get those technical tasks correct, you have to get the fundamentals correct first. Just like Charlotte was saying, it's a foundation, it's a scaffolding. You have to build it from the bottom, you have to spiral it up. And so I think not only is it about delivering that care and engaging our colleagues in practice, but I think it's about engaging all nursing colleagues across the board, the policymakers, the funders, the researchers, the nurse educators, the people that are out there delivering it. And yes, they're going in with real specialists, for example, cardiology knowledge. Yes, it's really important. And in fact, you can't feed a person who is having a cardiac arrest. You have to know how to deal with that. It's really important. But at the same time, we have to also value intrinsically the expertise that, for example, our colleagues in nursing homes have as equal. They are an equal expertise to those people who are saving lives. Palliative care is just as important. You know, a good death is just as important as saving a life. And so I do think it's recognising all of that and bringing it back into the core, as Lucy said, bringing it back to the core of nursing.
Great, thank you. And that makes me think about the ICN that have recently published their new definition of nursing and what it is to be a nurse. And very key in that is person-centred fundamentals care. So I do, we need to keep going back to that. And any of you that follow Jane Ball from the RCN, she's at the moment is very much talking around and challenging people around the role of the nurse and how you can't replace an RN for, an RN for a healthcare assistant or an RN for, a doctor for an RN, and how we all, I suppose what you're saying, Julie, we all have contributions to make, and there are sometimes some role boundaries, aren't there, that we cross over, but at the same time, we have that we as nurses deliver that fundamental person-centred care, and as you say, it's very complex and we can't be thinking about it as an individual thing, and sometimes we combine them. I'm just looking to see if there's any more questions in the Q&A. I think there's a few chats.
Yes, there's. Shall I?
Yeah, thank you.
Yeah,
thank you.
Natombi says, are there cultural aspects that might feed into this whole situation? Julie or Charlotte?
Yeah, actually, I think there might be. I think, however, it's cultural from perhaps a historical perspective. So, for example, going back as far as the 1601 Poor Law, the older people were relegated to workhouses. They were relegated away. They were suddenly seen as no longer able to contribute. And so I think we've got this cultural stigmatization running through our culture, that it's a bad thing to get old, and that suddenly older people are not contributing to society. There are other cultures out there that they feel that their older people do contribute to society. You know, they have wise old people that it's their job to support the community and engage the community and advise the community. And our culture, it seems, does seem right back to 1601, does seem to relegate older people. I've written a paper just recently in the Journal of Nursing Research that talks about defining age in older people as well. And the WHO and the United Nations, they say that to be an older person, it means being 65 years or above, or 60 years. United Nations is 60, WHO is 65, for example. But actually, at the age of 65 these days, life expectancy is much, much longer, much, much more. And therefore, at the age of 65, one of those older people, which I'm sure you're all absolutely thrilled about, might not need the same care interventions as somebody who's 85, for example, who's how the Age UK are now describing as the oldest old. And so it might be about really redefining what it is to be old in this country, and therefore what we need. Obviously, there are a lot of arguments, so that needs a lot more thought and a lot more conversation than that. But there is one argument there that we need to be really careful how we define old age and therefore deliver care in our culture.
Thank you. Thanks ever so much, Julie. Charlotte, we've got a bit of a debate going on in the chat here between Sarah and Sue around. So Sarah says that she agrees with Julie in the fact that we need to really think about redesigning, reimagining the nursing philosophy and models of nursing with people of the modern age and nursing skills and expertise. But then Sue has said, but there are actually some historical theories that have potential for contemporary nursing. So they're both in agreement that we need to really think about what nursing is needed today in relate to our population, our finances and, and so forth. But also, do we need to reimagine, or actually can we look at what we've already got? Any thoughts on that, Charlotte?
Yeah, I mean, it's really interesting because every time I look at the fundamentals of care framework, I always think, well, Roper probably defined that, and Henderson, said that, in the 60s, isn't that there are similar principles to Oram, for example? So I agree, we've got lots of nursing theories, nursing history that are really important, and we include those in our curriculum for exactly that reason. I also think that we've had various models of care delivery, which were, very much in vogue in the sort of late 80s, 90s, and have gone out of vogue. For example, primary nursing. In fact, I remember named nursing, which I'm sure was influenced by primary nursing. So we do tend to go around in circles, I think, with nursing. I suppose the challenge is how we lock things in. And I think that the fundamentals of care framework, in a way, has provided us another opportunity to bring back some of those theories, which I think are really important to practice, because they have the components of the physical care and the relational care and the communication and what have you. But they also acknowledge the context of the environment. So they look at the system level. So they think about things like the organisation of care, the type of care environment that the person is in. And I think that maybe nursing philosophies, what we've tended to do maybe, and the NHS has done this as well, is tended to provide a one-size-fits-all approach to how care should be delivered. So there could be some potential for nursing teams to start to sort of create their own sort of ideas about how they want their care to look again, I suppose. But yeah, it's an important debate, I think. So thank you, Sue, for raising that.
Thank you very much. Is there anything else in any of the chats or anything, Helen, that I've missed? Sorry, because they keep moving on.
I know. It's fantastic. So many interesting points being raised. Ine says some of the responsibilities for fundamental care have been reassigned to Band 3. And what are the implications for that? That's an interesting point. Julie or Charlotte?
Yeah, I mean, I think it goes back to probably the conversation we were having about, sort of person-centered care and how do we ensure a person receives person-centered care, and that relates to people's roles and appropriate delegation, etc. I do think that that efficiency, cost may have contributed to the sort of allocation of some of the fundamentals to band 3s and bands below. That doesn't take away the responsibility of the registered nurse for the overall assessment and the planning and the assistance with the implementation and then the evaluation of that care. And I suppose the risk there is that we see fragmentation, so that the band 3s get on and take responsibility whilst the RNs get on with other leadership prioritization tasks. So it's about making sure the connections remain, that the registered nurse has that oversight and has that overall responsibility and accountability for the care. But yeah, I think it's certainly an issue.
Lovely, thank you so much. Well, we are coming up to the end of this webinar. We've just got a few minutes left. So before I hand over to Helen to formally close the webinar, just once again, a real thank you to Julie and Charlotte, for sharing this great work that you're doing, and you know, being on the forefront of hopefully maybe, you know, changing some of the culture or the understanding of nursing home placements, and also actually re-lighting the how we can, you know, those placements, particularly where the fundamentals of care are, you know, might be seen much more as the bread and butter of the workforce, but actually how we can, they're the foundations of us as nurses, and actually we should be very proud that we're delivering the fundamentals, person-centred care, rather than it being seen as, like you say, Charlotte, the basic care or whatever. So thanks very much, and I'll hand you over to Helen just to close the webinar.
Oh, thank you. And thank you very much, Claire, as well, for pulling all of that together. Not easy thinking on your feet, you know, everything that's. So thank you very much. And thank you to everybody. And just as well, I think that really illustrates some of the issues that we get involved with here within the School of Nursing and Midwifery. And we like to sort of really explore and get underneath what's happening in nursing, and try and show some of the ways forward. And Julie, Charlotte and Claire, I think you all really illustrated that this morning, and thank you very much. So thanks everybody, thanks for everybody's contribution. For those people we said we would contact, we definitely will, and we wish everybody a pleasant afternoon.
Thank you, everyone.
Thank you.